very illustrative, and she was in need of at least 15 minutes more to cover this interesting subject of contrast mammography, the new emerging modality. And now we will invite Professor Doria Sen to give her presentation about the guidelines in multi-modality breast cancer screening. As we all know, Professor Doria is one of the big references in the field of women imaging.
Thank you, Mr. Chairman, for the presentation. Dear professors and colleagues, it's my pleasure and honor to be among you today. I want to thank the organizing committee, Professor Abdelrazek, for my invitation. I'll be talking about guidelines in multimodality breast cancer screening. But before that, there are questions that need to be answered about breast cancer screening. And that is, what is screening? And why should we screen? Whom to screen? When to screen? And how to screen? Well, screening is the evaluation of the population of asymptomatic women who have no overt signs or symptoms of breast cancer, and to detect clinically occult breast cancer at a smaller size and earlier stage when cure is still possible, aiming to reduce the number of women who die each year from breast cancer. Whom to screen? Well, the older a woman is, the greater her chances are of developing breast cancer. And as you see from this table, that 77% of breast cancer cases occur in women over the age of 50 years. When to screen? It is said that starting the age of 20, breast self-examination and clinical breast examination should take place. And by the age of 40, imaging should take place. And there is no upper limit in which screening should start. Between the age of 20 and 39 years, clinical breast examination should be carried out every 3 years. And after the age of 40, annual clinical breast examination and mammography should start. Needless to say that awareness is very crucial for screening. As you all know, that cancer grows for a period of time during which it is undetectable. It then enters a period in its growth during which it can be mammographically detected but is clinically occult. And this is what we call the sojourn time, and this is the perfect time for screening. Ultimately, it becomes clinically apparent. So what is the frequency of screening? All of the guideline developers recommend routine screening mammography with regard to frequency as follows. The U.S. Preventive Services Task Force recommends biannual screening, while the Cancer Permanent Care Management Institute recommends an interval of 1 to 2 years. The American College of Obstetricians and Gynecologists recommends screening to be offered annually, and it acknowledges that biannual screening may be a more appropriate or acceptable strategy to some women, and recommends the screening strategy should therefore be determined based on patients' individual risk values. So how should we screen? Is it breast self-examination, clinical breast examination, or imaging? And speaking of imaging, we have a multi-modality. Is it mammography with tomosynthesis, or ultrasound with elastography and Doppler, or is it with MRI? Let's see together. Well, speaking of breast self-examination, the American Cancer Society no longer recommends it, but women should be informed of the potential benefits and risks. They may then choose to do it regularly, occasionally, or not at all. While clinical breast examination is highly sensitive and provided there is good performance. Speaking of imaging, mammography is the cornerstone. But is it digital or analog? Although they have similar diagnostic accuracy, yet digital mammography has higher accuracy in women younger than 50 years. That is to say, women with dense breasts on mammograms. The American College of Obstetricians and Gynecologists, as well as the Cancer Permanent Care Management Institute, do not provide recommendation on digital mammography, But the ACOG states that a recent meta-analysis of data from 8 large randomized studies found that overall, digital mammography demonstrated a slightly higher detection rate than analog mammography, particularly for women aged 50 years or younger. And this is an example of a 58-year-old asymptomatic lady who came to us for screening. As you see, her digital mammogram shows nothing. But because of the tools on the digital mammography, with a push button you can invert the image and see more. With another push button you can get a magnifying lens, and here we can see 3 clusters of suspicious microcalcification. Ultrasound found no masses, and a wire localization was inserted, and this proved to be a multicentric invasive ductal carcinoma to which mastectomy was performed. And this is another case that appears to be apparently normal on the CC and MLO. However, with tomosynthesis, the speculated lesion was noticed. And this proved to be an invasive ductal carcinoma. So mammography should be performed for women at average risk for breast cancer annually with the age of 40. However, with women at increased risk for breast cancer, those with BRCA1, BRCA2, and their first relatives should be performed annually starting the age of 30. As well, for women with 20% lifetime risk for breast cancer, and for women with mothers or sisters with premenopausal breast cancer, they should be performed annually starting the age of 30 or earlier than the age of diagnosis of the youngest affected relative with 10 years. As well, women with histories of mental radiation, annual screening with mammography should start 8 years after radiation therapy. And for women with biopsy-proven lobular carcinoma in situ or atypical lobular carcinoma, atypical ductal hyperplasia, DCIS, invasive breast cancer, or ovarian cancer, mammography should be performed annually from time of the diagnosis regardless of the age. So to sum up, mammography should be done annually, starting the age of 40 for women, average risk, and for annually with starting the age of 30 for women, and increased risk of 20% or more. What about ultrasound? Well, ultrasound cannot be used as a primary test, yet as an adjunct to mammography in characterizing masses. It can be considered in high-risk women for whom MRI screening may be appropriate, but cannot be performed for any reason. The detection rate of cancer in high-risk women who undergo screening with ultrasound is around 0.5 to 1% versus MRI 2 to 7%. And this is an example of a suspicious lesion in the left upper outer quadrant, and ultrasound confirmed the suspicion by showing this pathological circulation on Doppler as well as the pathological axillary lymph nodes. And this is the case we've seen before that was apparently normal on mammography, and that the tomosynthesis showed the suspicious lesion. Look at ultrasound, how it helped to show the fuzzy outline of the lesion, the vascularity on Doppler, and on elastography it appeared to be hard. The case of invasive ductal carcinoma we've seen before. So the accuracy of breast ultrasound, as you know, is operator dependent. This creates an increased risk of false positives requiring follow-up exams and biopsy, which can be expensive and lead to unnecessary anxiety for the patient. To date, there are no data to establish that annual screening with ultrasound will reduce breast cancer mortality. However, there may be a subpopulation of high-risk women with dense breasts in whom the benefits outweigh the risks, and there is an ongoing multi-center study evaluating the use of ultrasound in this group. Currently, it is not the standard of care to offer or perform this examination. Speaking of MRI should be performed annually starting by the age of 30 for proven carriers of BRCA mutation and their first-degree relatives, for women with 20% lifetime risk for breast cancer. As well, should be performed annually starting 8 years after the radiation therapy for women with histories of chest irradiation, and should be performed as a single screening of the normal contralateral breast in women with newly diagnosed breast cancer. And it may be considered in women with risk between 15 and 20. And this is an example of a 34 years lady with a strong family history of breast cancer, and her mammogram was reported normal. And look at her MRI, it showed this speculated lesion over here in the right breast, and it showed marginal enhancement after contrast administration. As well, the kinetics were a type 2 curve, and this lesion proved to be an invasive ductal carcinoma. This is a right upper quadrant suspicious cluster of microcalcification, as you see here, by tomosynthesis, and her MRI proved an abnormal linear tracts of low signal intensity on T2 weighted image and showed enhancement with associated focal skin thickening, and this kinetics was very suspicious, type 3 kinetic, that proved to be a DCIS. So if MR is to be used, it should be in addition and not instead of a mammogram. This is because although MRI is a more sensitive test, yet it may still miss some cancers that a mammogram would detect. For most women at high risk, screening with MRI and mammograms should begin at the age of 30 years and continue for as long as the woman is in good health. Recent studies of women with an inherited risk of breast cancer have shown that MRI has a higher sensitivity in detecting breast cancers than other screening methods. However, there are no study data showing that MRI screening reduces breast cancer mortality. And these are the recommendations for breast MRI screening as an adjunct to mammography. Recommendation for annual MR screening based on evidence for BRCA mutation and the first relatives, as well as life risk 20 to 25%. And recommendation for annual MRI screening based on expert consensus opinion should be to ladies with radiation to chest between age 10 and 30, to Li-Fraumeni syndrome and other syndromes, as well as their first relatives. Insufficient evidence to recommend for or against MRI screening for lifetime risk of 15 to 20% for lobular carcinoma in situ, atypical ductal hyperplasia, dense breast, and women with a personal history of breast cancer. Recommendation against MR screening for women 15%, less than 15% lifetime risk. So the MRI's value in detecting breast cancer in most studies involving women at high risk for the disease. In a study published in the New England Journal of Medicine 2004, Dutch researchers followed around 2,000 women with a risk of breast cancer more than 15% due to genetic mutation or family history. For nearly 3 years, the women received yearly MRIs, semi-annual clinical breast examination, and yearly mammograms. Mammography detected 18 cancers but missed 22 that were found on MRI. However, MRI found 32 cancers and missed only 8 that showed up on mammograms. An Italian study published in the Radiology Journal in March 2007 showed similar results for a comparable group of high-risk women. In that investigation, 278 women were given annual clinical breast examination, mammograms, MRIs, and ultrasound, and in this study, 18 cancers were found. 17 showed up on MRI, including 6 that all other methods had missed. Another study in the same journal in August 2007 performed at 6 U.S. medical centers and compared MRI, mammography, and ultrasound. 171 women over age 25 whose life risk of developing breast cancer was more than 20%. 16 biopsies were performed and 6 cancers were diagnosed, all detected on MRI, mammography only detected 2, and ultrasound only 1. So the evidence of efficacy of MR screening in 6 studies carried out in Netherlands, Canada, UK, Germany, US, and Italy The sensitivity of MRI was around 100% in the US and Italy studies, and the specificity of the three modalities were above 95 in almost all. So the impact of MRI on screening: MR detects focal breast cancer in 2 to 5% high-risk ladies. Biopsy recommendation range from 3 to 32%, positive predictive value around 13 to 64%, and the negative predictive value around 1 to 29%. MR is more sensitive, detected DCIS, and the second look ultrasound for MR detected lesion is advisable. So your take-home message is: age 40 years, clinical breast exam and mammography annually or biannually, ultrasound adjunct to mammography to assess mass characterization. Age 30 years, high-risk ladies, mammography and MR should be done annually. And the second look ultrasound for detected MRI lesions is very advisable. Thank you very much.